Welcome to today's ASPA web series, The Troubleshooters in ART. I am Dr. Maruf Siddiqui, Clinical Director, Dhaka Fertility Center, Bangladesh. Also happen to be an ASPA board member who will be moderating today's webinar. So ASPA web series is an educational initiative focusing on inviting experts from diverse fields in infertility and reproduction. Usually we have a 1 hour live panel discussion. There is no presentation and it's full of interactions and answering questions from the audience. So today's topic is personalizing embryology, selecting the right technique for each patient. We all know that embryo selection technique is a crucial step in assisted reproductive technology, identifying the most suitable embryos for transfer through careful selection for achieving a successful pregnancy. A meticulous personalized approach in embryology is essential to identify the healthiest embryos, reducing the risk of miscarriage and genetic abnormalities while improving overall IVF success rates. Many key factors such as the patient profile, available lab resources, advanced maternal age, severe male factor infertility, recurrent implantation failure, etc., may guide choice of embryo handling or regarding the fertilization technique. This ASPA webinar emphasizes the importance of personalized techniques in assessing the embryo quality, optimizing the culture conditions, and applying selection techniques essential in determining the best embryos for transfer across the Asia-Pacific region. So we have three very eminent panelists on today's webinar, and they are Dr. Harun Latif Khan, Dr. Keshav Malhotra, and Professor Arthur Chang. Dr. Harun Latif Khan is the current president of ASPA. He is now as clinical embryologist and a sexual medicine specialist, and working as the chief executive officer of the Lahore Institute of Fertility and Endocrinology Life. And he's also the managing director of Hamid Latif Hospital. So welcome, Harun, on today's webinar. Our next speaker is Dr. Keshav Malhotra. Hello, Keshav. Keshav is the lab director of Rainbow IVF and now the director of Malhotra Embryology Training Academy. He is the vice chairman of embryology for Indian Society of Assisted Reproduction and also the chair of our SIG embryology for ASPA. Our last panelist is Professor Arthur Chang. Hello, Arthur. So Professor Arthur Chang is a professor of OBGYN at the University of Texas Health Science Center, San Antonio, Texas, USA, and director of clinical ART laboratories at UT Health Reproductive Health and Fertility Center and US Brook Army Medical Center. He is both certified as high complexity clinical laboratory director, embryology laboratory director, and clinical consultant by American Board of Bioanalysis. And he also happens to be a board member of ASPA. So welcome to all of you on this today's web series. So may I start with Keshav? So we'll be inviting questions from the audience, and by the time the questions up, let us discuss very basic things about this webinar. So Dr. Keshav, what is your opinion? How do you define personalization strategies in embryology for selecting the right technique? What is your opinion?
I think that's a very difficult question to answer, Dr. Maruf. Before I begin answering this, hello everyone and welcome to this web series. Really excited to listen to your questions and try and answer them. So for me, personalization in embryology and in the embryology laboratory basically means using all of the data that we have to kind of come up with a workflow for the laboratory and the lab choices, which ultimately would suit the couple's biology. I think the biggest limiting factor that we have in any clinic, in any country, is the biology of the patient. So we really have to tailor our approaches towards, let's say, what's the age of the patient, their AMH or AFC counts, the semen profile, looking at their sperm DNA fragmentation, certain genetic risks. And especially in our countries, and you'll agree with me, in India and Bangladesh, lots of patients have time constraints, they have budget constraints, and ultimately, all of our choices have to be made factoring in all of these inputs, and then only we can decide what kind of protocols we want to use, what kind of fertilization techniques to use. Again, freezing has to be optimized for such patients, etc. And we ultimately, like for me, my personal goal is to reduce time to pregnancy, because our patients can't really afford too many cycles and is not under insurance. So that's something that I would also factor in when I'm personalizing my approach towards that patient.
Okay, thanks, Keshav. So, in fact, we have to keep in mind that there are some developing countries in this region, and we cannot do what we wish to do in each and every aspect due to
Absolutely.
some constraint in our resources. So, but when there is the problem with resources, so in that case, Arthur, how do you want to personalize your techniques? You have no resource problem. So how do you approach in personalizing these embryology techniques?
Hello, everyone. Yeah, it's glad to be here to join this conversation with all the experts. So, yeah, actually, we are in the academic center in the university base, so we have a very limited resource compared to some like, yeah, wealthy private corporate centers. But it's very interesting that actually the academic centers in the United States, we do more personalized strategies because in the a huge corporate private centers, they do those, many of them do those like a factory assembly line, so they don't really customize for patients. So I would say, while in the United States we probably have more like a abundant resource compared to many other countries, we still have to work on which to identify which equipment and which technique actually can be prioritized. And for example, we can do a lot of add-ons to personalize, but some of them may not be the evidence-based. So I would say we will go from the evidence-based approach, then also check if our equipment, our sometimes it's not just equipment, the staffing, the embryologist proficiency, if they want to use the new technologies. So the human factor as well as equipment factors, both are very important.
Exactly, Arthur. So I think it depends on the protocol tailoring and what the lab technique you want to use, or you want to have a variety in the culture system, things like that. That would actually personalize your technique. The next question is, may I invite Dr. Harun Latif? So we have gone into the lab thing. So in your practice, regarding the patient, which patient group do you think benefits the most from personalizing embryology? What is your opinion regarding the patient group?
Thank you, Maru, for the for this. And sorry, I have some internet issues. C can you hear me?
Oh yeah, we can hear you. Please go on. I think by
I
the
think
time Harun
we've
gets
lost.
connected, we can continue. Okay, so what is your choice? What do you think? Which patient group benefits the most from personalizing this embryology?
I think all of them, because they all have certain requirements that we would want to think of when we are trying to personalize the approach. Like I would say, in my opinion, low ovarian reserve patients or advanced maternal age patients, they are ones that would really require certain extra attention. I get a lot of patients who have already had 2 cycles, 3 cycles of failures, and they are the ones who are now looking for that 100% guarantee from a clinic that they want a baby in the next attempt. I mean, those are those kinds. I'm sure we all get such patients, and these are their expectations, which we need to then cater to. And ultimately, obviously, we can't guarantee the success, but there are certain things that we would want to then test for. We probably improve our diagnostics before we start offering things. And like Arthur said, everything has to be evidence based. You have to take proper consents. You have to explain the success rates, and then only choose um, a modality that you might think might work for them. So lots of things can be done for certain profiles. Dr. Haroon's back, so maybe
Yeah.
we go back.
Yeah.
Yeah. Baruf, I feel that we all know that one size does not fit all, right? There's so many, like Keshav just highlighted, the number of patients, there's advanced maternal age, there is severe endometriosis, polycystic ovaries, severe male factors. There's so many who would probably need a customized sort of a treatment. However, having said that, we have to be aware of our limited resources, especially in the developing countries. And frankly speaking, a lot of times one size fits a lot of people as well. So, certain protocols, certain SOPs can be implemented across the board, and they work. A lot of times, they work pretty well. But then there are a certain set of patients, both with male or female infertility factors. Those need to be customized, and like Keshav named a few, especially those ones.
So exactly. So you cannot go in general way. You have to customize your patient and maybe personalizing embryology to that from that corner. So the dear audience, you can put your questions or queries in the question answer box, and three eminent speakers are there to answer your questions. So we can go to some basic scenarios that we encounter in our everyday life. So we will start with Haroon again. So Haroon, if we encounter a patient with an unexplained infertility with a normal sperm, so very basic ICSI or conventional IVF, what is your choice?
So, although what I've noticed over the years, a lot of clinics, especially the newer ones, tend to tilt towards ICSI a lot more, and kind of IVF is put at the back burner. And the mindset is that, we don't want failed fertilization, and there could be a problem. Might as well just do ICSI and move on with it. But I usually lean towards conventional IVF in the first attempt, especially if the sperm quality is normal, as as it respects natural selections and avoids unnecessarily intervention or extra steps. You don't want to give extra stress to it. So definitely conventional IVF should be the first choice until and unless contraindicated, such as history of prior fertilization failure, or fragile oocytes, thick zona, various factors like those. If you can see that, then definitely you'll move on to ICSI. Otherwise, the first choice should be conventional IVF.
Yeah, exactly. So do we all agree to that, or do we have any other opinion on that? Arthur and Keshav?
I mean, I would personally, I I would still do IVF in such a case. But what I would add is, like, we do an automated semen analysis. I just try and look at the velocities and all of the extra new stuff that's come up with these analyzers. I'd also maybe strictly look at the morphology once myself before taking up this case for IVF. And I mean, that's pretty much it. Sometimes in cases like you have unexplained infertility and they've had a couple of failures in other centers, in those scenarios, we might not do IVF, we'll just shift to ICSI. But again, it is customized to the patient's history as such.
Exactly. And I think there's a social problem also. We always have a fear back in our mind that if there's a fertilization failure, the patient might ask you, why didn't you go for ICSI? So that's a problem in some of the situations.
Yeah, in
So
our countries, it is a problem.
it's a problem. So
So
if you think in unexplained infertility, you have a lot of oocytes, can we split some IVF and some ICSI? Can we do that?
yes,
Okay.
I
Yes,
was just
we could do that.
Yeah. So I have a question, Maruf, with the two panelists regarding this. So with unexplained infertility, do you guys consider doing sperm DNA fragmentation test for every unexplained infertility patient now, or not? Before moving on.
I mean, we tend to do it for, I would say, 60 to 70% of such cases. We would factor in costs. If a patient is non-affording, then I would not add this test to like burden the patient a little, like more. But most of them go for this test for sure.
Yes,
Arthur?
I think that the DNA fermentation definitely helps, although, well, not in every cases, but in some cases it helps us to clarify the situation. So also there are the new devices we can actually use that in the IVF clinic. Right now, most of us, we send out those to like outside clinic or maybe some research lab in the university. But there are commercial products coming up and actually already available in certain countries. So I always think there are more clinics utilizing that machine. And also for the like fertilization failure, we tend to keep the sperm samples overnight, not throwing it away right away if we do conventional, because occasionally we can do re-insemination. And on the other side, we can do maybe rescue ICSI, and also we check the sperm quality. If the sperm suddenly crashed and died, often died in that vial or the dish, whatever device you keep the sperm, then that meaning we have some problem there.
Exactly. Exactly. So we have a question from the audience. I think it's quite difficult, and he wants to know that when we are dealing with a single egg in an advanced age patient with normal sperms, would you do ICSI or IVF? What would be your opinion, guys?
I would do
ICSI.
ICSI. I would do.
ICSI.
I think ICSI.
Yeah.
Even though there are people out there who would say that IVF works for single eggs as well, but I would not risk it.
Exactly, exactly. So that our next scenario is almost like that when there are very low oocyte yield, because we are encountering low AMH. I think in Bangladesh situation, I have receiving patients with low AMH increasingly. I don't know what's the situation elsewhere, but we are having difficulty in having a lot number of oocytes. So it's almost like that. So in very low oocyte count, which fertilization or embryo culture strategy would you choose? Anyone would like to answer to that?
I mean, in our clinic, we in such cases we generally counsel the patient for pooling, where even from the first cycle itself, they know that they will need a couple more cycles. And when I have about, let's say, 4 good 8 cell embryos or day 3 embryos, I then culture them to blastocysts and then move ahead with the blast transfer for such a patient. We've also attempted PRP for such patients, though it's a clinical intervention. We've seen that it does offer some amount of benefit. So that's something that we would look at. Plus, I mean, as far as culture conditions is concerned, it doesn't really vary for most patients. We'll still offer the same.
I
Yeah.
think so. The baseline is still the same. When you have go set count, go for ICSI. And usually
Mm.
we do not alter the culture conditions, is like something like that.
I mean, there
Yeah.
are options.
And
You can do GMCSF culture and all of that, but I haven't seen any
mm,
improvements. Harun, sorry, I interrupted.
yeah,
Arun,
yeah, sorry. So I think the extremely important part of what Keshav you mentioned in the beginning is counseling the patient, putting the expectations where the expectations should be. Especially in our part of the world where patients are paying out of pocket, cost is a big thing. So we have to explain it to them. Okay, this is what we're expecting. This is the spectrum we're dealing with. Of course, pooling would be an option that would incur some extra cost as well, but that would give us a better chance. Of course, it's cumbersome for the patient going through repeated cycles and all of that, but then the benefit is there. But we have to be very realistic with that. And like you said, that you don't really tweak much as far as culture is concerned or the rest of the processes within the lab are concerned. The only thing is that if you're keeping the expectation of the patient as close to reality as possible, then of course, with pooling, hoping with good number of certain oocytes, and then what we're talking about before that we go for ICSI and blast culture and accordingly forward.
I agree
Okay.
that the pooling helps a lot, especially with the low egg like oocyte yield, and also we would like to maximize the insemination. Occasionally, you have a low oocyte yield, then still have a one or two immature oocyte on the day, and we will wait till the next day to give those more like a opportunity. Like if there's a mature eggs, we'll still do ICSI on those. And nowadays, a lot of clinics practice freeze all, so that makes pooling a bit easier. And also, when we look back into the fundamentals, some labs might have a little bit lower blastocyst rate compared to others. In that case, some labs might still consider that freeze some at day 3, then that the cohort goes through on day 5. It's a kind of like a borderline strategy. So you have to, you have to see how good your blastocyst rate is. So how many blastocysts that you can end up with. If you consistent have for example, like a 50% blastocyst rate, then I'm not worried about those patients. I will keep going. But if we only have like 25%, then you might want to think about like a strategy which the patient will still have at least one embryo to transfer in the future.
Yeah.
Exactly.
It gets challenging when you only retrieve one egg or two eggs. And that's where I think it becomes very difficult, especially in our countries. Like I remember a case where I had actually done 4 cycles of stimulation, each cycle just giving us one egg each. And in out of those 4, we actually froze at day 3 for the first 2 cycles, and third cycle I took to blastocyst. It did not become a blastocyst. And fourth cycle, then on day 3 I took out the remaining 2, and there were 3 embryos that grew to blastocyst, 1 blast, and then we transferred that, and that resulted in a pregnancy. So I mean, it's ultimately it comes down to personalizing for each and every patient, and this is probably the most difficult category to personalize for.
Yeah.
Exactly.
I've been doing ICSI for 20
Yeah.
years now, and I still get very nervous when there's only one egg to inject. So
There's a trend
So
that I wanted to speak for in this category. I think I'm speaking to a lot of embryologists, and a lot of them are preferring oocyte activation for this group. Um, I personally don't agree with it because there's no indication for it. But what about the other 2 experts here? Would you use AOA right from the beginning when you have a low oocyte yield?
no, we
definitely not.
don't.
Yeah.
Yes, Arthur, please.
Oh yeah, I just we don't do that. We don't practice that right now.
Okay.
Harun?
Yeah. Yeah, no, we don't. We don't. I'm very skeptic about add-ons anyway.
Yeah.
So I'm very cautious about it. But yeah, so no, not in this particular case. Not in.
Exactly.
Maruf, I have a
Yeah,
follow-up
please.
question regarding this one. So if they only have a 1 or 2 eggs, and the patient say they really want to do PGT, as a physician, how do you communicate to them with the considering the risk and also benefits in that scenario?
Just like Harun, when my embryologists are doing ICSI in one egg, it's difficult for me to sleep until I did a fertilization. So usually I counsel them let's wait, let's see how it progresses. And if it goes to that level, we can discuss that and we can take a decision on that. Because sometimes you counsel the patient and there's a fertilization failure, becomes quite difficult to convince the patient. So usually as a physician, I prefer to go in a slow go policy. Let's see what happens and then I will talk with the patients. So
Yeah.
I think the next question is also a difficult one. We are having difficult questions from the audiences today. So they said that what's your experience of current advances in practically improving pregnancy outcome consistently in non-selected patients? Wow.
So, I just mentioned that I'm skeptic about the add-ons generally. We don't have, to be honest, enough data still that one particular add-on would really stand out and you would start using it, especially in non-selected patients. So for me, I'm very cautious about it and generally not yet convinced that something great is out there that can be used in your regular day-to-day practice.
I think that's probably the best answer that you can get, Dr. Maroof. A thing that I would add here is, I mean, if a patient comes and asks me, give me the best possible cycle that you can, I think I would add two things into the protocol. I would culture them in a time lapse system, and I would use microfluidics for sperm selection. I think these are two things that I would add. I personally like them a lot, and I have a bias for them, sorry. But when you look at data, there is no evidence to suggest any of these technologies work as of now. So we have to be cautious. We explain to the patient that we're not going to. It's not something that has enough evidence, and I mean, you consider all of those factors before you opt in for an add-on. But like, if I'm given a choice, I'll add these two.
Yes, I like time lapse as well. So although like there's no significance like showing that time lapse actually help you to improve the outcomes, but it's a good tool for the embryology. And also we can see more things we don't see from just traditional daily check. And a few years ago, the actually published this like guidelines on the add-ons, and it pretty much says most add-ons don't have a strong evidence. The only one they consider as a kind of like a medium level of the evidence is those we call like embryo glue and those used for the embryo transfer. So yeah, I'm not a advisor or KOL for the company. So yeah, that's what the actually only says that, but we don't routinely practice embryo glue. We don't routinely put embryo glue. So yeah, but I know that it's very popular nowadays.
Well,
Yeah.
I actually have shifted all of my cases to embryo glue. I've forgotten about it. It's become.
So that's all
Yeah.
about personalizing the embryology, not using embryo glue in each and every patient.
Yeah.
Maybe
I
in
think
some selected ones.
I think microfluidics has shown some really promising data, and this is something that could become really mainstream going forward because it's a simpler add-on to use in a way and pretty effective. What the data is showing. What do you guys feel about offering PGTA to everyone?
I mean,
Yeah.
we don't offer it to everyone. We are also limited by legal restrictions with the new law. So it's only offered to indicated cases. And again, the affordability is a big factor. So not many actually end up choosing it in a tier 2 city. In India, in a tier 1 city, the affordability is much higher, and people a lot more cycles would be PGTA cycles. But still, in smaller cities, it's a problem. Like we are not able to convert too many PGT cycles.
We also do selective patient population. So usually at like a advanced maternal age, or some of them like a unknown, like a repeating failure. So we might consider PGT. And oftentimes the others are, they really want PGT. So if we can do it and they are willing to do that, and with discussion with clinician and the embryology team, and the patient still want to go for it, we'll practice that as well. Yeah.
But are we heading towards in that direction? The once the cost comes down, and it's cheaper to run it, and the technology is more readily available for everyone globally, then would we eventually be doing it for everyone?
I don't know. I
We should not. Yeah.
I would
Yeah.
feel that if non-invasive techniques improve further in the next, let's say 5 years, maybe adapting that would be of a slightly higher significance than doing an invasive biopsy.
Yeah, exactly.
Mm.
So, can we move on to the next question? This is also a difficult one. If a previous cycle failed due to total fertilization failure, how can lab protocols be adapted for a personalized strategy this time? Arthur, you want to answer it?
What was the question again? Could
It's
you
a
repeat
question
that?
that if you had a previous cycle failed due to a total fertilization failure, you want to adapt a personal strategy for the lab protocols?
So right now, the first thing we would do is do more ICSI. Either you can start, like we mentioned, splitting cases, or we do all ICSI, and also see how the embryo will grow though. And AOA, like oocyte activation, we're not doing that, and there's no good evidence. In some clinics, they say, well, it doesn't make harm, it doesn't harm the oocytes, and maybe we should do that. So I'm still open to that strategy, but we are not doing that.
Okay. And what about the situation in India, Keshav? Because I think in Bangladesh, everybody goes for ICSI nowadays.
Yeah.
Almost no place for IVF. So what is the condition there?
Yeah, I think a couple of things that I would look at is I'll try and figure out what was the cause of fertilization failure, and whether it was lab factor or patient factor or whatever. I mean, if we can figure out if it's something to do with the laboratory, then we try and correct that, and then we can proceed with a regular ICSI case. If it's something that like if all of the lab conditions are perfect, everything was in perfect conditions, everything was checked, documented. In those scenarios, we generally use AOA for such patients. And I mean, in my experience, for the limited number of cases that I've done, it has benefited patients, but it's a limited number of cases. So, yeah.
I think, of course, you have to look at the embryology side as well.
Yeah.
So maybe run a DNA fragmentation test before trying another cycle, and the option of rescue ICSI is also there in that cycle.
Yeah.
What we've noticed that rescue ICSI, if done earlier than later, has better results.
Yeah.
So you could probably come back in 6 to 8 hours and see the polar bodies, and then maybe decide that okay, we can go for that. So that's another option. And of course, but when it happens, being an obsessive compulsive embryologist that we all are, we first think of the environment and the lab, and if everything is in place. But then, since if it's a busy lab, you have a number of cases, and if the other cases are doing well, then that's comforting, and then you can kind of narrow down to that particular patient.
Exactly.
Yes.
Exactly.
Yeah.
Uh,
And also we'll do the troubleshooting, like traditionally like a root cause analysis and all those. And by the way, I want to promote our embryology certification program, because we actually talk about all those scenarios in our very good like a basic in intermediate level program. So Kishev is heading like leading that project, and definitely encourage everybody to enroll in that program.
it's a very good program, we think.
Yeah. So that you don't have any failed fertilizations in your lab.
I'll take out snippets from this web series and use them for promotion.
So we do have a question from the audience,
Yeah.
and that is, what is the effect of duration between HCG administration and ovum pickup on the oocyte maturity in various group of patients? So, any of you want to start with that?
We tend to stay around 35 hours.
35 hours.
For the pickup. And then
Yeah.
ICSI, or when would you generally do ICSI?
We tend to do it under 39 hours from the
Yes.
HCG.
Around 4 hours, 35, 39. So,
We stick to 36 and 39. And in certain cases, I mean, in my cutoff is I should not be crossing 40 hours
yeah,
for ICSI itself. But I think the question is that the effect of HCG timing and maturation of the eggs, if I'm not mistaken. And I don't think there is any like differences in various groups of patients. Um, if the egg is not maturing, or if you're getting more number of GVs and M1s, I think we have to go back and look at the size of the follicle and all of those things, because the biological process of maturation should finish within the stipulated time. And the eggs that are not mature in that period might not have the best prognosis, even if they mature within the next 3 or 4 hours. So that's what I would say in such a case.
exactly.
I think the KPI is around, is it 80%, 75 or 80? 80%, right? Of getting M2s
Yeah,
per
but
follicle.
from follicles more than 14 mm.
Yeah.
When you have, as a clinician, what I think, when you have a good quality follicle with good estradiol level, good endometrial thickness, 35 or 36 hours may not be a very important factor. I think almost all the cases you'll get the same thing. Arthur, you want to add something?
Oh, well, actually, that was a question I was going to ask you as a clinician. What's your suggestion?
So I think we are all in consensus about that. May we proceed for the next question? If we have a high sperm DNA fragmentation, would you change your sperm selection method?
I think for me, microfluidics is the way forward. Of course, you get good quality sperms who have less or no DNA fragmentation. The only thing is, if you have a low concentration in the sample, then that could be a problem. And if you have low motility, then of course the sample on the other side may not be enough, or you won't have enough sperms. But if the parameters are within a certain range, then microfluidics really works well. We have other options like Pixie is there for sperm selection that can be done. Clinically speaking, you could maybe treat DNA fragmentation with antioxidants for a period of 3 to 6 months' time before actually getting on to stimulation and moving on with the cycle.
Exactly. Keshav, you want to add something?
I actually don't want to add anything. That's a perfect approach. We also follow this
Exactly.
3 to 6 months of antioxidants. If it's resistant, then we do microfluidics and or Pixie, um, whichever technique feels better for that patient. I prefer microfluidics in my clinic, but like Dr. Haroon said, there are certain factors that limit the use of microfluidics. So we just need to factor those in. That's it. I rarely shift to invasive approaches where we take testicular sperm for ICSI. I mean, it's not something that I would do for high DFI because we have non-invasive techniques.
Exactly.
I would
Doctor?
also recommend the sperm sorting devices as well, either microfluidics or the membrane based. Those are two major approaches that commercially available. And some brands gives more sperm passing through and some gives fewer sperm passing through. So if you have a more sperm passing through, then maybe there's a still opportunity to do conventional IVF. Otherwise, in many cases, when we do those microfluidics or sorting, we end up doing ICSI on those.
Exactly. Exactly. So let's move on to the next question. We have a question from the audience. What is your take on IVM for the new era of stimulation-free cycles? Is this the way forward? Oh, very interesting.
Yeah.
Arthur, you want to answer that?
So it's a very interesting question. I mean, the IVM itself looks like it's a trend. So it has moved from originally it was used as a backup strategy, the kind of rescue strategy, and now it's doing like to save money and also in some cases to minimize the stress of stimulation. And it made me remind me of those like a mini stimulation, like a treatment before. And personally, I feel there's a subpopulation which can benefit from IVM, but in general, we should still go through the traditional, like full stimulation in most cases. And in some cases, if the patient could have a risk from the traditional stimulation, then we can consider IVM. But the outcome so far is still open for debate, I would say.
Exactly. Arun and Keshav, you want to add something to Arthur's comments?
Personally, we're not doing IVM in my clinic, and I don't have much personal experience in this. But of course, I agree with Arthur what he's saying that the data that's coming out definitely it's a good option for a certain subset of patients, and yes, these results are pretty promising now.
Exactly.
Yeah, I personally don't believe in the near future that all of the cycles would benefit from IVM. I think we really need when you read the news and when you read all of these big headlines saying only 3 days of stimulation would be required for IVF. I think that really plays with the mind of the patient, and they have to understand that we are still not matching the FERT rates, blast rates, pregnancy rates that we would achieve from standard stims. So
Not even close.
no, exactly. So I
Not
would
even
still
close.
prefer a standard cycle as compared to an IVM cycle, even though it is less painful, less number of days. Benefits are there, but ultimately the patient wants to take home a live birth, and that's something that we should factor in. So there's still time for it, I think.
Exactly. Maybe we will be
I,
able to comment on that after 5, 7 years. A better comment.
I would say just like many things in our life, like good, fast, and cheap. You probably can choose two out of those three. It's very difficult to take care of all three when you think about stimulation and treatment.
Right. Okay, so let's move on to the next scenario. So if you encounter a case of severe male factor infertility with fragile oocytes, so what is your option? You want to use a conventional LIXI or a PIXI or maybe an IMSI or an assisted oocyte activation? So Arthur, can we start with you?
Yeah, that's a very tricky one. So if we have a fragile one, meaning like oftentimes when you start doing ICSI, the egg just lies.
Yeah.
So we will try to split the case, and we could try the Pixie and MC. However, those might not actually help the fragile egg issues though. So it's more like helping the sperm side. So when you have a fragile egg, the easiest one would be split the case. And I haven't done any assisted oocyte activation on fragile oocytes, so yeah, I really cannot say much about that. How
Arthur,
about
what about
the others?
AFC, the new technique that's out there where they are trying to fuse the sperm head to the membrane?
Mhm.
Just thinking
I
maybe
haven't done that though.
I also
Yeah,
haven't done it, but
it's very interesting, and maybe that's a more gentle way to fertilize.
for especially this category, I feel.
I think besides these add-ons, the skill set is integral when it comes to cases like these, right? So you can, you can reduce your denudation time and, make certain tweaks. But end of the day, you have to have the most experienced embryologists performing these cases, and because the basic structure of the treatment will not change a lot. So if done in experienced hands, then you can get good reasonable fertilization rate with fragile eggs. And of course, we've talked about poor sperm quality, in which we have, MCs probably there, but we can do microfluidics, so better sperm selection techniques. Yeah.
I think we are almost near the end. So let's move on to some embryo selection and transfer strategies. So what do you think? What is the correct thing? You depend on morphology. You depend on a time lapse with or without morphokinetics, or you want to go for an AI-based scoring. So these are the newer things. So how do you personalize these things in your lab? What is your approach? Keshav, you want to start?
Yeah. I think for most patients, we are still sticking with standard morphology. I think if you do it well, the results are pretty good, matches everything. And all of the other techniques have not been shown to be superior than standard morphology. They might be non-inferior, but they're not superior. So in most cases, standard selection is based on morphology itself. The only thing is that your embryologist has to be good in grading these embryos. I sometimes, because I have the access to a time lapse, I would use time lapse systems and the morphokinetic scoring as well. Uh, but it's mostly done in cases where I have lots of blastocysts and then I want to prioritize embryos for transfer. Nothing more than that. And AI, I personally feel that AI is beneficial for chains of clinics where you have n number of embryologists who are involved in scoring embryos and grading embryos. So in order to just standardize the selection process, I think AI can be very useful in such clinics. But in standalone clinics with good embryologists, I think morphology performs quite well.
Exactly. Harun, you want to add something?
Not not much to add. I think Keshav has highlighted all the aspects of it. Uh, I feel that one should be careful that the subjective part of morphology assessment should be addressed. At times, if you have a certain number of embryologists and they're all doing it independently, then it's good to have at times kind of an audit or an outside eye, just to see where everyone stands and just to bring everyone on the same page. That definitely has an impact on on your outcome. Uh, of course, all these other techniques, including time lapse and going forward AI, they are non-inferior. They would take the burden off the embryologist working in the lab, and the subjective nature would also be addressed. But as of now, this morphological assessment is the main tool that we use in our lab.
Exactly.
And with Alpha now, with the new Istanbul consensus, everything has been made more clear.
Yeah.
So we'll actually be doing a webinar in November on this. So I would request all of you to to sign up for that, and we'll take you through all of these aspects together.
Okay. Thanks, Keshav. Arthur, you want to add something?
Yes, I totally agree with Harun and Kishav. So in our lab, we still use like mainly the traditional like a Gardner like grading system, but we also use a time lapse as a kind of like a secondary. Just as Kishav said, we can use that to prioritize or deselect the embryos which show those like definitely negative like parameters. And for AI, it's very interesting. So most AI or if we include the algorithm based those approaches, there are many research being done, but there's no universal like AI or algorithm can be applied to all the clinics. Oftentimes you kind of really optimize those algorithms in your clinic, then turn out it doesn't fit the other clinics. Then if we want to do more generalized, then it's too simple and doesn't make any like outcome improvement in most of the clinics. That's a kind of dilemma.
Exactly. So we have discussed about a lot of advanced things, but I want to ask Harun and Keshav that there are many smaller clinics in India, in Pakistan, or in Bangladesh. They may not have access to the latest technology. So what are your advices for those clinics? How can they improve their outcome by personalizing their embryology techniques?
I think, Maruf, we the basic thing is that we need to stick to basics. That's extremely important. You know, your environment, your culture conditions, your skill set, the basics. You don't need anything fancy or any other add-ons and, AI-led these things. So if you're starting off, then just sticking to these basic SOPs, which are, readily available, which are easier to implement. I think you can achieve excellent results with just doing that. And once, of course, the clinic is up and running and you've had certain experience, then you can take up difficult cases as well and customize according to the needs.
So just stick to the basics.
Yeah,
Yeah.
I also agree with this. I would just add that you train in such clinics, training of embryologists and getting the right people in your team is absolutely crucial. So invest in your embryologist more than investing in these add-ons. I think that's one message that I would want to give to the people who are listening today, because like we've all gone through the whole couple of decades of IVF. For the last 10-15 years, success rates have, I mean, they plateaued. So what we were doing 10 years, 15 years back, even if we are mastering that, we'll still be able to offer very good success rates to our patients. So I would not really worry too much about tech as of now. I want to focus on raising the standards of embryology in these countries.
Exactly. Thank you, Keshav. I think we only have a few minutes left. So I want to ask Arthur, what is your opinion? Do you think that the personalized approaches significantly improve the live birth rates, or are we still in the early stages of proving this? What is your opinion, and what is your take-home message for this webinar?
So the personalized strategy, I would say definitely help some subgroups of the patients, like subpopulations, just like all the add-ons. And as Keshav and Harun mentioned, those like embryology skills are also very important. You could apply the same technique but have different outcomes. So I would say sometimes you cannot distinguish is the embryologist issue or is a technology issue though. So I would also encourage like a add on like not add on like a follow up on the concept of the embryology. So if you have a small clinics, a limited resource, then your probably the best strategy is giving your embryologists more educational opportunities so they can go out and learn more things from the others because they might not have other like mentors in their own clinics. So they can actually add on their knowledge, not the add on technique, but the add on knowledge is definitely helpful.
Exactly. Thank you, Arthur. So may I go to Keshav now? So this is a difficult question because when you want to personalize embryology, then how do you communicate the value of this personalized technique to patients who may be overwhelmed by too many choices? So how do you counsel those patients, and what is your take-home message for this webinar?
I think so. I have been speaking a lot on automation and AI and all of these strategies, and what I'm seeing currently is that there is so much out there which starts personalizing the IVF process right from when the patient walks into the clinic. You have chatbots which will take their patient history. You have AI softwares which try and personalize stimulation protocols based on the patient factors. And I feel that those are scenarios where, because there's so many factors that you can input in, there's a very nice paper that looked at inputting everything, the 20, 30 factors like age, BMI, your AMH levels, basal hormone levels, etc., all of these things, and then coming up with a strategy for stim for patient. I think these are things that will really personalize the approach towards the patients rather than things that happen in the laboratory. We only have limited things that we can do in the laboratory, but outside the lab, to optimize the health of the patient, to optimize like outcomes after pregnancy. I think that's where the major focus will lie in the near future. So my take home message would just be to like be aware of things that are coming up and then try and see what you can improve within your own setups without increasing the burden to the patient.
Exactly. And in fact, it is also difficult for the patients to decide, because when my embryologist gives two, three options to the patient, they become a little confused. And they just come to me and say, do whatever you decide is good for me. So sometimes when you give too many opinions, too many options to them, it becomes difficult for them to decide.
Our patient profiles are not up there as compared to the Western world as of now. So I think
Exactly.
it's important for us to also be selective in our communication
Yes.
to them so that we don't confuse them.
Exactly. And personally, I think this would be the best thing for you. So let's go for that. And nearly all of them, they agree to that. So we are almost at the end of the program. So as my last question is to Harun, before giving a take-home message, as per president, I would like to ask you that how do we balance these advanced techniques with the cost, accessibility, and equity, especially in these resource-limited settings across Asia Pacific? Okay.
So, Maruf, I feel with all these latest expensive technologies, the gap is being widened, uh, kind of haves and have-nots kind of a scenario. What we need scalable, affordable solutions that can be implemented, especially in the developing countries. We need low-cost culture, media. We need affordable drugs. We need robust quality assurance, quality control systems that are not expensive. So these cutting edge AI tools are great. They're amazing. I'm all for it. But there's much more to do, especially in large part of the world, which are developing countries, where we need these affordable solutions for all of them. For our young embryologists, my take home message, I would shamelessly promote that you should sign up for the Aspire certification basic course. And those who've done the basic course should sign up for the intermediate course, come to Beijing, and you have the opportunity to get the certificate and hang it on your lab wall.
Exactly. So we're almost at the end of our program. I think we have a very good discussion. The problem is in each and every year we go to the conferences and we see something very new for the labs. But at the end of the day, we do not know how the live births are going to increase. So that's quite difficult. But still, we continue to strive what we are now, and we're trying to improve ourselves day by day. So thank you all the speakers for a nice discussion, and thank you all the audience for joining us in this ASPA web series. Till then, till the next web series, it's goodbye from all of us.
Thank you.